Thank you everyone for joining this workshop. Today we're going to be looking at under-delivery of IV antibiotics, the hidden contributor to global AMR crisis. So this is following on from Ruth's talk this morning. My name's Phil Hazeldine. I'm an A&E nurse and working at Braun Medical as a clinical therapy manager. And this is my colleague Claire.
Hello, yes, my name's Claire Davies. I'm a paediatric nurse and I'm also employed by Braun Medical as a clinical therapy manager.
So before we get into the session, hopefully a lot of you have scanned the QR code that was on screen when you came in. If you haven't, you can just shout your answer out. Just got a few questions to throw at you before we get into the session. So the first question is, how many of you have heard of the issue of under-delivery of IV antibiotics before you attended today? So if you can just give you a few seconds to have a vote. I'll give you a little bit longer on this first one because I can see a few people scanning the QR code.
I'll go back one.
Oh. Okay. So, people are still voting. It keeps jumping back and forth. Well, always a technical issue, isn't there? Most people have said no. Brilliant. So, really important that you're all here then to learn a little bit more on this subject. It's fantastic that so many people actually have heard of it, but for you who haven't, hopefully you'll take a lot away from today's session. The next question. How many litres of prescribed IV antibiotics do you think are discarded and not administered to patients each year in the NHS? Now, there's been a few clues to this. Okay. So amazing that most of you got it right, but it's absolutely shocking to think that 9 oil tankers full of IV antibiotics are discarded every year. And this is something that we want to avoid. And so hopefully leaving here, we can take forward to our hospitals to counter that. And finally, how many IV gravity sets do you think are used in NHS year just for IV antibiotic administration? So not for everything else, just for IV antibiotics. I'd love to say there's a prize, but there isn't. Amazing. Always aim high. 20 million sets just for IV antibiotics. Now, by giving, obviously, the total dose, the total delivery of these antibiotics, hopefully we can reduce some of that set usage as well. I'll pass over to Claire now.
Thank you. Okay, so the next few slides are to recap a little bit on what Ruth delivered to you this morning in her plenary session. So first of all, how does this under-delivery of the full dose of antibiotic occur? So us as clinicians, when we administer an infusion, an intermittent infusion, we invariably choose to use a pump infusion set or a gravity infusion set. Regardless of the method you use, when the infusion finishes, the administration set remains partially filled with air, but also partially filled with a volume of the residual drug. And when, as clinicians, we dispose of this administration set, we are also disposing of that residual drug. And depending on the size of the original bag volume of your prescription drug will depend on how much you're discarding, but it could be up to 40% of that original prescribed dose. And if we're focusing on antimicrobial resistance, it's important to note that about 60% of these sets we're discarding with medication in them contain antibiotics. So this slide is back in just for a bit of clarity, really. When we talk about infusion set flushing or line flushing, we aren't referring to flushing at the needle-free device attached to the cannula, which we routinely do when we disconnect an administration set or after we've given a bolus medication. Clinically, that's routinely done in UK hospitals. But what we are talking about is the image on the right here, flushing of the actual administration set to ensure that the total volume of the drug is administered to the patient. And that's only routinely done at the moment in paediatrics, oncology, and haematology. So where do we stand in terms of word from our influential bodies guiding us of what we should be doing with respect to flushing infusion sets? First of all, we have the INS standard, published only in February this year. This guidance has been published to say we should be flushing our administration sets, and then with added focus on the importance of doing this for antimicrobial drugs to make sure we minimise the loss of that drug. Secondly, on screen, we've got the Royal Marsden Nursing Manual. This publication recently had its text amended to encourage us again that we should be flushing our administration sets before discarding them in order to give the full dose of the patient's medication to them. And then thirdly, the NEVAS flushing guidance is telling us the importance of administering all of the prescribed dose of medication. And then they go on to offer us 2 methods in which to do that. So for the next part of the workshop, I've got pleasure to welcome Ruth Dando back to the stage. Ruth is the head nurse for theatres, critical care and anaesthetics at Barking, Havering and Redbridge University Hospitals NHS Trust. Thank you, Ruth.
Thank you, Claire. So carrying on from what Claire and Phil have explained, and also in addition to my earlier speech, I'm going to go on and give you a bit more detail around the impact of failing to flush the IV administration lines and not deliver the full dose, and also my journey with this project and how I've addressed it within the trust I'm working in at the moment. So despite my many years of nursing with line flushing embedded in my clinical practice, it was a stark realisation when in conversation with Lynn from Braun, how the lack of line flushing was leading to underdosing and the implications this had. So it was clear to me that this needed to be addressed, which is why I set about implementing a change in practice to rectify this gap in care. Being responsible for the critical care service at BHRUT placed me in an ideal position for implementing a change to our practice here. It is a large service comprising of 57 beds across 2 sites, including a specialist neuro critical care unit. Like all intensive care units today, it's busy, with high occupancy rates and high patient acuity. Here we manage the sickest patients of the hospital. We see a high number of sepsis cases from both community and hospital-acquired infections, resulting in patients requiring multiple intravenous antibiotic infusions. So what motivated me to implement line flushing in the service? It was simple. The need to get things right for our patients. Once I had an awareness of the gap in care and the implications, it was essential to me to rectify this. Patient safety. It's at the forefront of our care, and anything that compromises this must be addressed. Inadequate early treatment of sepsis can result in the onset of multi-organ failure, increasing the risk of mortality in something that is treatable. 5 people die from sepsis every hour in the UK. We have the Sepsis 6 management tool, with one key element being the delivery of IV antibiotics. If underdosing occurs at this point due to lack of line flushing, there is a risk of harm from deterioration. As previously mentioned, antimicrobial resistance is a real and concerning threat to healthcare globally. The UK government, in their 20-year vision for AMR, have outlined its commitment to contain and control antimicrobial resistance through strong mitigation by lowering the burden of infection, optimal use of antimicrobials, and a full antimicrobial resistance research and development pipeline for antimicrobial alternatives, diagnostics, vaccines, and infection prevention. Given this, the contributing of underdosing and incorrect disposal of antibiotics, National Health Service organisations have a responsibility to address what they can as soon as they can to support this. The cumulative effects of underdelivery of antibiotics means that over time, patients end up missing out on significant amounts of their prescribed treatments. Inevitably, this will lead to delayed recovery and extend patients' lengths of stay, not only in critical care, but also in hospital. We are all aware of the high demands on hospital beds, with safety implications of not being able to deliver care at the point of need. All measures need to be taken to minimise the need for hospitalisation through rapid treatment and early recovery. Implementing the line flushing in critical care was approached via a number of steps. Firstly, we need to decide on which method would be the optimal one for patients, staff, and also procurement, with considerations of costs to be factored in. It was decided that to procure the safe set flush would be the best solution in supporting our ability to support this important change in practice and allow us to deliver antibiotics in line with the nationally recommended guidelines. Reasons that we regarded the safe set flush as the desired option was threefold. It minimised the number of disconnections of lines, which would be more efficient for nurses to use and reduce, and for the risk of fluid overload, with the volume of fluid limited to the amount required. In looking at the process of IV medication administration in our units, it was interesting to analyse this in detail, as it came to light that for every medication given, a new line was used. It had not been flushed, so had been changed each time. So it was an additional bonus to the service that adopting this practice would likely to see a reduction in sets used, plastic waste, and potential cost savings. These are significant benefits on top of the patient safety and antimicrobial improvements we were setting out to achieve. The next step towards implementation was to ensure buy-in from all the relevant key stakeholders. This included the critical care, medical and nursing teams, the trust procurement team, pharmacy, microbiology and IPC. On presenting the issue of under-delivery of antibiotics and the implications of this to my clinical colleagues was met with a great deal of support. There was an element of, how did we miss this? And of course we must flush our lines to deliver the full dose. Procurement teams were also very understanding of the need, and being able to evidence the patient safety and antimicrobial resistance improvements, as well as the anticipated reduction in sets used, helped with their buy-in, as we could show how the additional costs of the set would be easily offset. Whilst procurement can at times be sceptical when clinicians are requesting approval for different consumables, they are also understanding of the need to strive for improved patient care, with clear and measured rationale of the need and benefits help to get them on board. And here, whilst I had little data to demonstrate my ask, the logic behind the practice was evidence enough. I created a SOP in line with the national guidance and submitted this for review and approval through our Quality and Safety Governance Committee. It was important to have clear guidelines available to share with the teams ahead of the implementation. Communicating the ask and conveying the expectations of what is required from the teams was crucial in making sure the important players in this, the staff who would be adopting this change in practice, supported by the Braun medical clinical therapy specialists, we launched this new practice for delivering full dose of intermittent IV antibiotics across the critical care service in January 2023. As I previously mentioned, as I started looking into improving our practice in IV antibiotic administrations, it highlighted the ways of working across the units. Multiple number of lines are used per patient per day. With the safe set flush, which could remain connected when flushed and used for subsequent doses, we were looking at a significant reduction in sets used. As we are striving to adopt more sustainable ways of working, this has proved an added benefit for us. It has also led me to link in with the Trust and North East London's sustainability networks, partnering together to increase the reduction in plastics and consumable waste across the network. As there is limited evidence pertaining to the practice of full dose administration, it was important to us to make sure we captured the data for our service, and have been working closely with our procurement team and Braun to evidence changes as we have progressed the implementation. Comparison in use of sets has been as we had anticipated. Using 2019 pre-COVID data on our first year of using SafeSet Flush, we saw a reduction in use of around 1,300 sets per month. This was very encouraging as it covers a time period when the process was new and not fully embedded. With the support of the pharmacy team and Braun, we looked at our antibiotic usage. In the months of December 2022, pre-introduction of antibiotic line flushing, and December 2023, which is 11 months post-launch of the new practice. Looking at the 5 most commonly used antibiotics within critical care, there was a reduction in usage in all 5 groups, totaling 21% fewer antibiotics delivered, and this was adjusted for patient bed occupancy days. Again, these results are as we had anticipated, based on the logic of delivering the full dose. And further analysis of antibiotic use, our use of second and third line antibiotics, as well as rates of recovery, critical care lengths of stay, are all important metrics we will continue to be looking at to assess the impact of line flushing in our service. In June of 2023, I was asked to respond to a Freedom of Information request sent to the Trust from the House of Lords. They were making inquiries nationally to explore the practice and policies pertaining to the flushing of intravenous lines following intermittent medication infusions, as well as the practices around disposal of antibiotics. In replying to this, and from gaining a deeper understanding around the request from discussions with Braun, it was clear to me that this was something that needed to be delivered trust-wide. Firstly, care to our patients needs to be equitable, and those receiving intravenous antibiotics in other areas of the hospital should receive the same standard of care. Replicating the steps I took for implementing the practice in critical care, I linked in with the nursing and medical teams in the clinical care groups, as well as reviewing the need for a trust-wide implementation with the key stakeholders as before. The SOP was reviewed and amended to align with care delivery in the ward areas and how the line flushing needs to be managed in ambulatory patients. Usual practice on the wards is to disconnect the administration set once the infusion is completed. Obviously, once disconnected, it had to be discarded, so the reduction in numbers of sets used is not anticipated to be as we have seen in critical care. However, in examining current practice with the absence of line flushing, additional sets are used for additional antibiotics for the same patient. So with the implementation of line flushing, we would hope to see some reduction in use. Making the process easier with pre-filled syringes is also an element of improving the process to make it more efficient and less time-consuming. Key points of training for the process had been the adherence to best A and TT practices when assessing the needle-free connectors, and to always administer the flush at the same rate as the antibiotic dose. As with any change in practice, there are challenges and obstacles. It's not been easy, and we're not there yet. The main issues we have encountered during the trust-wide rollout has been getting consistency in the practice changes in all ward areas and supply issues due to varying demands in the areas. Ongoing communications and team huddles and quality meetings, as well as continued support in all the clinical areas from the Braun team, as well as the Trust's PDN and IPC specialist, is providing a coordinated and collaborative approach to ensure that full dose administration of IV medication becomes the norm. An audit tool has been developed to monitor compliance, and this will help provide assurance that safe practice is taking place, as well as identify areas that require further training or support. It is important, though, to also consider how this rollout is being delivered against a backdrop of clinical staff facing high workloads with operational and workforce pressures, and it cannot be underestimated the difficulties that implementing change in these circumstances create. That being said, myself, the Braun team, and champions of this in the Trust remain resolute in continuing to persevere. We're expecting to see the same benefits that we have started to demonstrate in the early and initial data from critical care. We also anticipate the ability to switch from IV to oral antibiotics will be accelerated, which in itself will reduce medical device and consumable costs, reduce consumable waste, and reduce hospital length of stay. Additionally, nursing time will be saved in less time required for preparing drugs for IV administration. We're looking forward to seeing a reduction in antibiotic prescribing, with less reliance on second and third line antibiotic treatments, and the clear benefits this will have on reducing antimicrobial resistance and drug-resistant infections. In summary, the flushing of intravenous lines following infusion of prescribed medication needs to be reinstated as routine practice. Patient safety sits at the heart of this and is the foremost important reason that this needs to be done. Recommendations from the report following the Freedom of Information inquiry launched last year is that this needs to be adopted nationally and monitored by regulators. Antimicrobial is an existing and real threat. Action is needed now to ensure we have some weapons remaining in our antibiotic arsenal for future generations. In a time of increasing financial pressures, any element of improving healthcare efficiencies and reduction of unnecessary use of consumables needs to be embraced, along with the sustainability benefits for a greener approach to our healthcare delivery. Thank you. Sorry.
Thanks very much, Ruth. Before everybody runs off, I will have one more question for everyone in the audience on Slido. Some great insight there of how to go and use this template really to make sure we are delivering total dose antibiotics in our hospital, whether starting in an intensive care unit or going hospital-wide straight away. So just pop this last question up now. From the first question, about 60% hadn't heard of this topic before. So how many of you in the room now would support the introduction of post-medication flush in your organisation to ensure that the total dose and delivery of IV antibiotics is administered to your patients? I'll let you have a vote at that now. Just while you're voting, if you've got more questions, we can ask Ruth and myself and Claire for a few minutes now. But also, Braun have got a stand upstairs in the main room where we can demonstrate the safe set flush line to you, talk through how other hospitals have gone about it, and give you any information that you require. Thank goodness for that. Thank you so much.